Right? So say you've done the antibiotics, you've done the fluid, you've done the pressors, you've done the steroids. Blood pressure's back up. At what point are you going to start the patient on any bicarb drip? So I said the number one rule in patients of septic shock is to source control. Another important thing, anytime you're managing anybody in a shock state, for me, if there's one problem that I would always fix, it is going to be acidosis. I do not like acidosis in my patient. As per the guidelines, when the patient with septic shock, you get a pH and the pH is less than 7.1, you have to start them on bicarbonate. In DKA less than 6.9, you have to start them on bicarb. Why do I not like acidosis? All enzymes in your body are proteins. What happens to proteins in the presence of acid? It gets denatures. So can any of your enzyme, end of the day, all of us look human, but we are all just pure biochemistry. We have millions of enzymes in our body working to do whatever it is doing. So if your body is becoming acidotic, can all those enzymes work? They can't. So your enzymes in your body cannot work, and therefore it's bad. What else is the reason I do not like acidosis? Can your pressors work in an acidic environment? It cannot. Your pressors will never work on an acidic environment. What else do I not like acidosis? Acidosis equates to arrhythmia in my head. Whenever you have too much H+, what happens to the H+? H+ gets shipped into your cells in exchange for what? Potassium, because potassium is primarily intracellular. So if you have acidosis, you'll almost always have hyperkalemia. And what would hyperkalemia do to you? Arrhythmias and cardiac arrest. So acidosis is the worst possible thing that can happen to your patient. So if somebody is getting acidotic, fix the acidosis. You better be after that like a hawk. If you can fix the acidosis, you're going to save this patient. What else can we do to a patient in septic shock to improve their perfusion? Would you give them blood transfusion? Because end of the day, I said a patient is in a shock state because the cells in your body are not receiving oxygen. So now you giving fluid and pressors, fluid to fill up the tank, pressors to squeeze everything so you increase forward perfusion. But end of the day, ultimately, who's carrying the oxygen? There's RBCs and hemoglobin. So if I gave somebody blood on the context of septic shock, say the hemoglobin was like 8, and I brought it up to a beautiful 10. Now I've increased the oxygen carrying capacity of the patient, right? So wouldn't my tissues get more oxygen because I've increased the oxygen carrying capacity by giving more blood? Sounds like a wonderful idea. What do you think? There was this whole protocol that was discovered. It was developed by Dr. Rivers. That was called the Rivers protocol. One of the things he did was he actually gave patients blood to increase the patient's hemoglobin, and we were targeting more closer to like 10 to increase oxygen carrying capacity. That way you're going to perfuse the organs, and therefore you're not going to do so much anaerobic glycolysis and everything's going to get fixed, which is a absolutely wonderful idea. But anytime somebody comes up with a great groundbreaking theory, what do the rest of the humans like to do? Disprove them. So what trials came out and said, no, he's actually wrong. You should not be giving blood transfusion unnecessarily to increase oxygen carrying capacity, because blood, you don't have so much blood to give everybody. Number one, giving other people's blood to somebody else, antibodies, there could be tons of reactions, ABO incompatibility, rhesus incompatibility. You can have DARCO, you can have TRALI, you can have febrile reaction, you can have all sorts of problems. And end of the day, real question is, was it really necessary? Do you really need 10 hemoglobin to solve this problem, or could you have done that with just 7? The answer was 7 was good enough. You giving too much blood only is raising volume in your patient, a lot of side effects, a lot of reactions, so don't do it. So which were the 2 trials in critical care that said not to target 10, stay at 7? TRIC and TRIS. Transfusion indication in critical care, and TRIS is transfusion in septic shock. TRIC and TRIS trials basically said no, you do not need to target 10, targeting a 7 is good enough. So say a patient comes with septic shock, her question is, should you be trending the lactic acid? The answer is yes, you should be trending a lactic acid. Back in the day, we should trend lactic acid every 4 hours until the lactic acid has actually cleared out. Yes, so you will be trending a lactic acid in your patients, Q4 hourly to Q6 hourly. Now, whenever you get a BMP, it tells you what the bicarb is. But regardless of that, you still want to get lactic acid too. You want the lactic acid to clear out. And you want the bicarb on your chemistry to improve. You don't necessarily have to keep getting pHs and doing ABGs. Definitely don't need ABG, but you can do a VBG. ABG is only going to give you oxygen in addition to all the other information. A VBG is good enough for you to see a pH. So a venous blood gas to see what the pH is, a lactic acid and bicarb becomes very relevant. How frequently you're going to check it on patient is really dependent on patient to patient. But should you track it until it fixes? Yes. Well, my bicarb is now 24, but the infection is still there. So therefore the process is still continuing. Should I just keep going to a higher number? What do you think about that? Should you give more bicarb? Maybe your lungs are okay, but if you have a patient with septic shock, can their lungs get affected? Say they didn't have pneumonia, but they're in septic shock because of a urinary tract infection. What can septic shock worsen to become, which is going to affect your lungs? Sometimes your patient with septic shock comes, they're okay, their blood pressure is low, you're treating them, mental status is good, they didn't have an oxygen requirement initially, you're flooding them with fluids, and suddenly you feel like, hey, what's up with this patient? The patient is suddenly starting to have an oxygen requirement, having an increased difficulty breathing. What should we be worried about in those patients? It could be two things.
ARDS.
You can think of ARDS, right? Adult Respiratory Distress Syndrome. Or say you overloading the patient with a lot of fluid so they can become fluid overloaded. So that's why giving somebody fluid initially is important. First 24 hours is very crucial, but after 24 hours of resuscitation, don't flood them. Assess what the volume status is and go back down on your fluids. That's important. If not, the patient is going to get fluid overloaded. But you can also develop a lung pathology known as ARDS. How do you define ARDS? What was the definition of ARDS?
Is it bilateral lung infiltrates?
Yes, you're going to have bilateral lung infiltrates that could not be explained by any other reason. What else? So PaO2 over FiO2 ratio should be less than 300. If you have a PaO2 or FiO2 ratio less than 300, that is the very definition of ARDS. And all of this should have happened within the past 1 week. So those are your three criteria, and this criteria is known as Berlin's criteria. Very good. So once you go into ARDS, if the patient from septic shock, which is the classic patient, will develop ARDS, the moment you come below 300 of PaO2 over FiO2 ratio, we call this mild ARDS. What makes it moderate? Less than 200. Less than 200 becomes moderate. Less than 100 becomes severe. So you go mild, moderate and severe. Now when it comes to ARDS, okay fine, you know to identify, that's very important. What are you going to do about it? Well, do you always have to intubate? If the patient is requiring a small amount of oxygen, can you get away with a BiPAP? Intubation is not always the solution to every problem. When it comes to the treatment philosophy of ARDS, it is to do with positive pressure ventilation. Can you achieve positive pressure ventilation with a BiPAP? And when would you do proning in your patient? What should your PaO2 or FiO2 ratio be in order for you to prone somebody?
Less than 100? No, that was too.
Less than 150. Less than 150, you're going to prone them. Now remember, ARDS was classically seen in patients with
COVID.
Well, previously was septic shock, but since COVID happened, most patients with COVID develop ARDS. That's how they ended up on a ventilator with ARDS. Who else can get ARDS apart from septic shock patients and COVID?
Pancreatitis.
Pancreatitis, very good, because pancreatitis essentially follows the very same philosophy of infection. It's just that you're getting an infection and your inflammatory cascade is going wild. Pancreatitis, you're releasing all these enzymes which is going to cause a hyperinflammatory state, and that is part of the problem which is going to cause ARDS. When you have ARDS, do you want to give them more fluid or you want to keep them dry as possible?
Dry.
You want to dry them out. Almost think about this, all this fluffiness you see in those lungs is just fluid. So you give them a lot of diuretic to get all the fluid out, and you want to keep them as dry as possible. So pancreatitis is another one you want to think of getting ARDS. So the reason I speak about this a lot